Wake up. It's the Sleep Unplugged podcast, episode 190, Restless Leg Syndrome Shakeup. Every time a problem ends, another one begins. Welcome, everyone, to the Sleep Unplugged podcast. My name is Chris Winter. I'm a neurologist, sleep specialist, and your host for this episode of the podcast. If you're new to the Sleep Unplugged podcast family, welcome. If you're a veteran, welcome back. We're glad you're here. We're especially glad you're here because this podcast really came about because of listeners' questions, and I'll get to that in just a minute. If you have a question about restless leg syndrome or sleep in general, you can contact the podcast at any time you want through our social media. That's Dr. Chris Winter Instagram, Dr. Chris Winter Twitter X, Dr. Chris Winter Blue Sky Threads. We have a dedicated YouTube page where we post all the video content of our shows. The podcast has its own web page as well. That's at sleepunplugged.com. I've written two books, The Rested Child and The Sleep Solution, Why Your Sleep's Broken and How to Fix It. Both books address restless leg syndrome, but not to the updated level that we're going to be talking about today. Real quick, we had a sponsor set up for this show, but because I switched this around, I actually bumped the topic for this week, which is creatine and sleep, to next week. So the sponsor for that was Sleeping Dove, who has sponsored our episodes before. They were awesome. I said, look, this is kind of an urgent issue in terms of some of the changes set up and announced for restless leg syndrome treatment. I think it'd be a good idea for us to do this sooner than later. Can we postpone the creatine and sleep till next week? They said, absolutely, you can. So I want to give a shout out to Sleeping Dove Comforter Company. They are wonderful people, and we'll talk about their comforter next week. Real quick, listener said, who was on, there was a listener wanted to put on there. Sorry, I don't have the name of the listener. I didn't put it in my show notes, but this was from our YouTube page. They commented on the orexin agonist podcast that we did back in November. That was episode 178. And the comment says, what I'm interested in seeing is if the orexin agonists are going to affect our nighttime sleep at all, specifically whether or not it will allow our brain to correctly cycle through the correct sleep stages with a proper amount of stage 3 slow wave sleep. I'm extremely excited at the results impacting daytime sleepiness and cataplexy, but I would absolutely love to get off of oxybates. Worst case scenario, I really think they will pair well together. Very excited. This was from Hubba Wubba 1988. Hubba Wubba, I agree. This is a very exciting time to be in hypersomnia, narcolepsy, idiopathic hypersomnia, that whole space, because that orexin agonist group of medications that are on the way is very exciting. If that's something that you missed, please tune into that episode and check it out. Musical group for this podcast is Vampire Weekend, and the line "Every time a problem ends, another one begins" is one of my favorite newer songs by Vampire Weekend. This was off of their fourth album, Father of the Bride, which came out in 2019. Very successful album. I think it won them at least one, if not two Grammys, and I believe it was the first time they had ever had an album up for Album of the Year. They didn't win that, but I think they won Best Alternative Album of the Year. It might have been the second time they won it. I think they may have won that from their debut album, which was just called Vampire Weekend. Everybody remembers that. A-Punk, Oxford Comma, great album. This is all Ezra Koenig and crew. Ezra Koenig, I think, dates Rashida Jones from The Office, and she was just in that really interesting Black Mirror episode. Great actress. Big fan of Vampire Weekend. They formed at Columbia University, where the producer of this show, Maeve, did her master's degree and currently works. So shout out to Columbia. Harmony Hall is actually a dorm at Columbia. It has nothing to do with the song. In fact, when I listen to the song, I think it sounds like a sort of song being sung about like a retirement home for people who have dementia. talking about seeing snakes, seeing things that aren't there. I don't want to live like this, but I don't want to die. Something that kind of resonates with me in terms of sort of elder care and what it means to come to the end of life with cognitive illness. It probably has nothing to do with the meaning of that song, but I do love it. And so we'll put that on here. And it reminds me too, Danielle Haim, the singer and guitarist for the group Haim, actually sings background on this. And I don't think we've ever featured Haim on this show, so I'm gonna have to figure out a way to get them on here as well too, because they're a great newer group. So we'll put Harmony Hall on the Spotify Music playlist. If you want to find those playlists, the little codes for finding them on Spotify are on the Sleep Unplugged webpage. So let's get into this episode. How did it come about? Within about a 3 to 4 day period, I had two individuals contact me. The first was an older woman who's been on dopamine agonists for some time for her restless leg syndrome and said, I just saw an article from Harvard that came out that said maybe this isn't the best therapy. 3 or 4 days later, a younger individual and their partner contacted me and said, hey, we take gabapentin and we saw some distressing information out of Mayo Clinic, is what they said, about the link between dementia and gabapentin. So I wanted to circle back and really touch base about restless leg syndrome because now what we have is newer, and I say newer because these came out, the AASM task force that sort of looked at the way we treat restless leg syndrome and put out sort of best practices. This all came out at the beginning of last year. So it's been out for about a year. And I don't know why I didn't really think to talk about it on the podcast, but because you guys are such engaged listeners, I was like, yeah, I've really screwed up by not talking about this because it really does create sort of questions for a lot of people that take dopamine agonists. And now you throw in, okay, well, what are we supposed to do? And the guidelines say maybe start with gabapentin. Oh, wait a minute, that drug has been linked to dementia. So really stuck between a rock and a hard place. In fact, I thought about the song off of Steel Wheels, Rolling Stones, Rock in a Hard Place for the song of this episode, but I'm not a huge fan of that song. I never liked it. I loved Mixed Emotions off that album and Can't Be Seen, but I really was never a fan of a Rock in a Hard Place. But I do like Harmony Hall a lot, so I think we made the right call. So here we are. Every time a problem ends, another one begins. So I think that is a perfect title for the podcast because restless leg is a big problem. So I think if you're a listener to the podcast and you're thinking, well, it's just restless leg, who cares? Restless leg can be a murderous condition. I have it myself, not to the degree where I take anything, but believe me, there are some red eye flights and some other situations I get into where if somebody handed me a medication for my restless leg, I'd probably take it on the spot. So what's the big deal here? So the big deal is for a long time, we have used dopamine agonists to treat restless leg syndrome. The most common two are ropinirole, which used to be called Requip. I mean, it's still called Requip. That was the non-generic name for it. And Pramapaxol, which was Mirapex. So Requip and Mirapex were the two big drugs that we used to use a lot for restless leg. And those drugs are used for Parkinson's disease because they enhance dopamine. So important to understand that when we're talking about using these dopamine agonists, we're not using them to treat Parkinson's disease. We're talking about restless leg syndrome. Why does that work? It works because it is thought that restless leg comes about because of some dysfunctional dopamine regulation in the brain. And if we go back about a year and some change, we give out a book of the year, a sleep book of the year. And I invite you, if you want more information about restless leg syndrome, please check out the book by our good friend of the podcast, Andrew Spector down at Duke. And I think we can title him Good Friend of the Podcast, Neurologist, restless leg syndrome expert. And I think we can throw in a new title for Dr. Andrew, which is ACC champion, because he works for the Duke Blue Devils in their sporting teams, and they won the ACC football championship this year. So lots of titles and feathers in that man's cap. If you really want to get more information about that, check out his book, Navigating Life with Restless Leg Syndrome. I think it's a fantastic, fantastic book. Anyway, so we have used dopamine agonists for a long time. Why? Because they enhance dopamine, which is signaling improperly in patients with restless leg syndrome, particularly at night. I think it's worth going back historically and saying, okay, when we started using these drugs, what had we been using prior to using dopamine agonists? Well, we were using drugs like Sinemet, which is a carbidopa levodopa. It's sort of a precursor for dopamine. And analgesics, we were using benzodiazepines and opioid. We were using all kinds of stuff that wasn't great. And when the dopamine agonist came along, why did we start using those initially? Because of fewer episodes and less problems with augmentation and rebound. So what is augmentation and rebound? Essentially, that is the medication that you're taking for the condition, making it worse over time. And the actual intrinsic nature of your restless leg is not really getting worse. The best example of that I see in my sort of neurology world is migraine therapy or headache therapy, where somebody says, look, I get crushing headaches once or twice a month. So, I take ibuprofen, acetaminophen, I take over-the-counter analgesics for it, and they help. But as time passes, I've been getting a few more headaches than I would like per whatever time period. And now suddenly I'm getting headaches every day, despite taking 2 to 3 times the amount of analgesics I'm supposed to. Now, that doesn't happen overnight, but over a long period of time, the medications that were a lifesaver for your headaches have now become the cause and the driver of the worsening of your headaches. That's sort of augmentation and rebound. Rebound being, I get a headache, I drink a cup of coffee, it gets a little bit better. As the coffee's metabolized, it comes back stronger, so I need to drink more caffeine, kind of thing. So I think that historical perspective is important, because we got to dopamine agonists because we were trying to avoid augmentation and rebound. So now here we are, we're in the beginning of 2025, and now the new guidelines basically say, hey, because of worsening conditions over time, and I believe it's something like 8% of people on dopamine agonists will augment or rebound over, a relatively short period of time. So it's, if all the people taking the dopamine agonists, 8% every year are going to develop augmentation or rebound. That's a big number. Let's call it 1 in 10. We'll call it 10%, 1 in 10. So the AASM, which is the American Academy of Sleep Medicine, the governing body of sleep, has basically said, look, we would rather you take the alpha 2 delta ligands. That's Neurontin, a similar drug, Lyrica. There's Horizont, which is, again, a very similar, all in that same family. That we would rather you take the Neurontin, Lyrica, Horizont drugs because we see less augmentation with those. Great. Number one, I think a lot of people already use those drugs kind of as first-line therapy, even though I don't believe Neurontin has an FDA approval for it because it's a generic drug. Horizont has a very specific indication for it. So I think a lot of people are already using these medications for restless leg syndrome. So if not, if you've never been on it before, you've only been on dopamine agonists, and you're doing well, and you've been doing well for a long time, great. You're probably in the 90% of people who haven't had augmentation or rebound this year. Now, it may be coming for you. Or number two, and this is really important, you've got a provider who understands what's going on and knows how to manage these medications properly, which I think is a really important thing to say about dopamine agonists. Now, there are other things you can do besides gabapentin and the alpha 2 delta ligands and the dopamine agonists, Mirapex, pramipexole, ropinirole, Requip. Checking iron, making sure your iron levels are great. There is a new product called Nidra, which I've recommended to so many patients. I don't know that I've had a patient follow through with getting it. Little device that you wear on your legs. You can look it up, Nidra, that kind of gives little impulses to kind of disrupt that signaling back to your brain. So it's a wearable device essentially, and I'm really excited to find out more information about it. It's relatively new. I'm just having a lot of trouble getting patients to bite the bullet and jump in there and get it, despite the fact that I have a lot of patients in my clinic who are not thrilled with their restless leg therapy. Why are they not thrilled with their restless leg therapy? Because I think I'm a pretty good provider of restless leg care. Where we get into trouble with the dopamine agonist is this: you come to me and I diagnose you with restless leg syndrome, or it's gotten so bad in your life that you've come to me. And we see a lot of people who have been treated somewhere else and then come to us. So, do I see the augmentation and rebound? You bet I do. And here's how the story goes. And I want you, if you're a patient who has restless leg syndrome and you're getting restless leg care, I want you to tell me if this sounds familiar to you. You were diagnosed with restless leg syndrome and somebody put you on a dopamine agonist. Let's say somebody put you on ropinirole, started you at 0.25 milligrams about an hour before you went to bed, and you've now titrated up to zero point 0.5 or 1 milligrams before you go to bed. And it was a game changer. It made all the difference in terms of your restless leg. And as time passed, okay, 6 months later, I'm doing great. A year later, you know, I'm feeling more often than not when I sit down to watch a little bit of A Night of the Seven Kingdoms or The Pit or the new season of Alone or whatever you're watching. And I'm having a little bit of trouble with my restlessness. Oh, okay. Well, you're only taking 1 milligram of ropinirole. The FDA approved max for restless leg is 4. So let's bump you up to 2 milligrams. Guess what happens? Exactly. It makes things a lot better. It solves the problem. Hey, how are you doing since we bumped? Oh, it's fantastic. It's outstanding. Great. Okay, well, I'll see you in 6 months or a year, or whatever the follow-up is. 6 months later, doing well. 6 months later, I don't know. I've just really been struggling. We got a hot tub. It kind of helps, but not really. It's sometimes I've been taking a little bit of extra medication and that helps. I'll sneak an extra ropinirole pill and take 3 milligrams. And that seems to do the trick on those off days where I'm having a problem. That is a big red flag. I'm every now and then, it's no big deal. Every now and then I take a little extra of the dopamine agonist. That's the beginning of the end. So what you start to see is a long game. It's a protracted worsening with little periods of getting better in between when the individual takes more medication. The more medication works, and then it very much doesn't work over time. And you can see where this ends. Okay, now we've worked you up to 4 milligrams, the maximum we're supposed to give for restless leg, and it worked for a period of time, but now you're back. And now what do you do? Well, you could do 5 milligrams. I mean, couldn't you 5? It's just a little bit more than 4. Why not? Let's check their iron. Iron's fine. Are you exercising like crazy? Okay. And what's so frustrating about the new guidelines is, hey, are they exercising? Hey, did you check iron? Yes, we do that for everyone, right? Got any better ideas? No, you don't, because we don't have great therapies for restless leg syndrome. And that's what's frustrating about the guidelines is it's not, hey, out of the 20 different drugs for high blood pressure, you might not want to take this one because of an increased risk of heart attack or whatever. It's not that. It's we've got basically 2 drugs we use for restless leg. Now, when I say 2, I mean 2 drug classes. When you look at dopamine agonists, there's also something called a Nupro patch, which is rotigotine. What kind of drug is that? You bet it's a dopamine agonist. And brother, insurances hate paying for it. but it's a patch you put on. And instead of taking that medication right before you get to bed at night, it's constantly putting a little bit of dopamine agonist in your bloodstream. So this individual is basically saying, I've reached the max. What do I do? And a lot of the patients that we see go right through the barriers of maximum dopamine agonist therapy and go into what I would consider to be high dose dopamine agonist prescribing. And there's a lot of that going on. In fact, I remember a patient that was being treated at a big university hospital situation a couple hours south of me. And I got the notes because when this patient came to me, 4 times the amount of dopamine agonists they should be on. That was 16 milligrams when they went to bed. And at that point, the person treating them said, why don't you go see somebody else? And they came to see me. So when I got the records, it was fascinating. They weren't even going in to be seen. They would just call their provider and say, ooh, my restless leg's kind of bad. And they immediately got an increased dose. Every call, increased dose, increased dose, increased dose, 16 milligrams of dopamine. We don't know what to do. Go see Chris. I said in my first, I wrote a lot about augmentation and rebound and this kind of thing in the Sleep Solution, Why Your Sleep's Broken, How to Fix It, my first book. And I likened it to Frankenstein, that Victor Frankenstein built his monster out of the best intentions and realized very quickly the Frankenstein creation, which is not called Frankenstein. Frankenstein is the doctor. The entity that he created is not Frankenstein. It drives me crazy. So this entity he creates, he cannot control anymore, and it runs amok. That is how you make a monster when it comes to dopamine agonist therapy. So as these conditions start getting worse, as it starts spreading into the arms and getting to the point where a person can't even sit still to watch, it's always interesting because you can tell it's augmentation and rebound because the symptoms are 10 times worse than they were when the person came to see you. So if that person had come to see that doctor that wrote 16 milligrams of dopamine, and the doctor said, I choose to do nothing nor allow you to take any treatment, I can almost promise you, fast forward to that point when they're on 16 milligrams of dopamine agonist therapy and needing some help, they're in a worse situation than they would have been had they never even been treated in the first place. So the mark of excellent restless leg therapy, and this is something I have thought about my entire career, because as simple as it sounds, treating restless leg, I'll just give them some Repinerol. It's really easy. I can imagine how simple that would sound to a primary care doctor. And I'm not giving primary care doctors a hard time. I'm just saying that the nuance here, I don't think you've been trained on. Because the nuance is when I meet a patient with restless leg, I tell them, restless leg is like the stock market. The stock market just went down for whatever reason, probably because we're thinking about it invading Greenland, or nobody likes the way ice is being dealt. There's reasons for it. But so the stock market went down. So what does that mean? You pull all of your money out of the stock market? No, not at all. In fact, you might want to do the opposite, right? During down periods, that's probably a good time to invest. Oh man, the stock market's going crazy. It's super high. What does that mean? Invest, invest, invest. Maybe, or sits tight, or what? So because it's going to come back down. And then it'll go back up, and it'll come back down, it'll go back up. But the general march is upward, right? I think restless leg is kind of like that, maybe slightly in the reverse. The general march is slightly downward. But one day, between now and when I see you again, you're going to have a really rough restless leg day. And I tell my patients, you can call me, but generally speaking, I'm not going to do anything for you. I'm going to listen. I'm going to care, but I'm not changing your medications. And the line I give my patients all the time is, it can be a lot worse than it is tonight. So you have a bad Thursday night? Yeah, okay. Sorry to hear that. I'm guessing Friday will be much better for whatever reason. I can't explain why Thursday was bad. I can't explain why Friday was better, but it's going to be okay. So you're going to have some series of nights that are kind of rough. Migraine patients, sometimes you're going to have a migraine despite excellent prophylactic and abortive therapies. You're going to get a migraine. Doesn't mean your therapies don't work. You just had one breakthrough. And if every time you have a worsening of your restless leg, you're getting increased dopamine agonists, the doctor that you're dealing with, they don't know what they're doing. That is the making of a disaster. And that's what Winkleman and the Harvard group is trying to protect against. People who aren't entirely sure what they're doing. I tell patients all the time, okay, we went from 1 milligram to 1.5 to 2 very quickly. I'm a little concerned here. I have a lot of restless leg visits that result in me doing nothing because I know that doing something and making improvements in the short term can actually be much worsening in the long term. I always ask my patients who are really fighting augmentation and rebound, who are in the throes of it, where would you rather be? Where you are today or where you were when you first came to see a provider for your restless leg? They always answer, oh, I would much rather be where I was first diagnosed for restless leg. Okay, so I know what you're thinking. Well, Chris, let's just go to gabapentin and forget it. Like, don't worry about it. Like, just let's be on gabapentin. Clearly, somebody feels like it doesn't cause as much augmentation and rebound. It's safer. Awesome. What is the problem here? Well, the problem is there was a 2025 paper, which was a Trinex retrospective study looking at chronic low back pain and found that if you were given more than 6 prescriptions of gabapentin, and believe me, if you've got restless leg, you're getting way more than that, you had a much higher incidence, you had a higher incidence of dementia, and you had a higher incidence of cognitive impairment. Relative risk of dementia, 1.29, relative risk of mild cognitive impairment, which is an easier bar to clear, 1.85. And this seemed to be higher in individuals who were a little bit older in that population. So, and this was a British Medical Journal, regional anesthesia, medication, risk of dementia following gabapentin prescription in chronic low back patients. Um, I don't, I'm trying to figure out what, I think the date was 2025, I'm pretty sure. I'm not sure where I can see where the specific date of it was. Yeah, I believe it was 2025. Um, so I think this is extremely important for people to understand that this is a relationship study. What does that mean? What it means is we're back in the realm of autism and Tylenol. There seems to be a relationship between people who take Tylenol and people who have autism. There seems to be a relationship between people who carry around cigarette lighters and people who get lung cancer. Right, because cigarette lighters cause lung cancer? No. But there's a strong relationship there. And there's a relationship here too, but we have to be very careful. Why do we need to be careful? This is a patient population with chronic low back pain. Chronic low back pain often indicates other disorders and a lot of other medications. So we have to be very careful about that. Pain in itself, the inactivity that comes along with it, the depression that comes along with low back pain, the sleep disruption that comes along with low back pain, all of these things independently are linked and can confound us when we start looking at dementia risk. And if we want to add to that, there was a Taiwanese study entitled The Association Between Gabapentin Use and Risk of Dementia in Adults with Chronic Pain, a Nested Case Control Study. This was from August of 2024. And I'm going to read from the highlights of the study. Rising global dementia prevalence, growing attention to chronic pain and potential risk factors. Taiwanese health insurance database spanning 2000 to 2019, so 19 years, assessed dementia risk in gabapentin. This is a very common way they do studies. Just look at these large populations of people, find people with low back pain, find people who have dementia, I'm sorry, on gabapentin, follow them out and see who gets dementia and who didn't. This study showed that gabapentin use was not linked to a higher dementia risk. No elevated dementia risk was found across varying dose levels or among different age groups and gender subtypes. So, what do we actually do here? Number one, I think we consider things, right? I, does a relationship imply causality? No, but it often doesn't mean it isn't there. And we have to be very careful about that. So, would I be shocked if 10 years in the future gabapentin was linked to dementia? I actually would, because this drug has been around forever and we've never really seen this signal before. Now it's being used more and more, so more and more individuals who are, struggling with different things are being exposed to it, so I can see where it could be linked to a lot of different chronic health issues. It's hard to find people sometimes who are taking more than, say, seven medications. Gabapentin is in there. It's probably one of the most prescribed medications out there. I mean, when that drug was a name brand drug, I think they got into a lot of trouble because they were promoting it in a lot of different ways that were not FDA approved, which is fine to do that. You just can't, as a company, promote it in that way. So, what are we supposed to do here? Number one, when it comes to restless leg syndrome, look for anything that you can identify that might be a cause or exacerbator. Meaning, has your doctor checked your ferritin level? Are you exercising? Could you be pregnant? Might you have a thyroid disorder? Are there any other medical disturbances there that could be lending themselves to exacerbating your restless leg syndrome? Number two, if appropriate, and again, all this stuff you have to talk to your primary care doctor about. If appropriate, I think alpha 2 delta ligand drugs, Neurontin, gabapentin, Lyrica, are fine. They're great. They're perfect to start off with. If they work for you, awesome, because maybe they're going to cause less augmentation and rebound down the line. Now, what's going to be interesting is to see as we tidal wave change everybody over to gabapentin from dopamine agonists, are we talking about the same thing in 5 years? Here's my prediction. I'm on record as saying we will have the same problem with this drug that we did dopamine agonists, meaning you're on 300, it's working well. Come back to your doctor. It's not working so well. Okay, we'll put you on 600 milligrams hour before you get to bed. 900, 1200. And the thing about gabapentin, there's not much of a ceiling with that drug. As the late, wonderful Ivan Logan said, who was one of my professors in residency, the only way you're going to hurt yourself with gabapentin is drop it on your head, fill a bag full of it and drop it on your head. So I think the nature of this disorder is one that is restless, no pun intended, and the disorder is always slowly wanting to march towards worse. It's weeds in your garden. Get out there and you pull all the weeds out and your garden looks great, but just give it time. Give it time. They work their way back into the situation. It's just the nature of the disorder. So I think that it's very important for us all when we're treating restless leg to tell people, is it in your long-term best interest to change or go up on the medication? Can we give it another week or two and see what happens? I tell my patients this all the time. It's like my theory about back surgery. When you can't take it anymore, wait 3 more months and then do the back surgery. Man, the number of people who are like, oh, I can't take it anymore. And they wait 3 more months and like 3 weeks later, their back gets better. And they're like, okay, I'm not doing the back surgery. So listen, there are times to go up on medication for sure. But we have to be very judicious in terms of finding those times and identifying them. So it's important to also understand that the American Academy of Sleep Medicine, Harvard, all these people have basically still said, yeah, you can use the dopamine agonist. It's okay. But we've got to use them with caution and we have to monitor for augmentation. And I'm going to go a step forward. It's not just monitoring for augmentation. It's educating our patients about what that is and what it looks like, because the definition of rebound and augmentation, if you look at it on Wikipedia, is kind of dry. It's not a living thing. It seems sort of, oh, well, I'm not going to let that happen. And it's always happening. So we have to tell people what it really, really looks like. And again, there are AASM recommendations for other medications besides these two, opioids, benzodiazepines. I think those are very special situations. But again, the nature of this disorder is rough. And there are people who are like, look, I'll take the risk that if this will allow me to sit still at night. So we cannot underestimate how bad this disorder can be in some people. So I think it's important that we think about these guidelines in a much broader sense and thinking about augmentation and rebound in every patient that we see, every visit. So the answer here is not panic or a big change in what you're doing, but just better diagnosis, more thoughtful, individualized care, and really making sure we're looking outside the box at other therapies when that is possible. So here's a quick list of research mentions. AASM 2025 RLS PLMD guideline. You can look that up. The Harvard Health, there's a Godman study, accessibility, explanation of augmentation, why dopamine agonists fell out of favor, and how dopamine agonists can still be used cautiously. Great, great paper to look at. We talked about the Egarahi et al. 2025 study about the gabapentin lower back pain. Winkleman, who was, I think, head of that task force for the AASM and RLS, wrote an article in 2022, Sleep, High Dose Dopamine Agonist Prescribing Patterns in the US. Very concerning because of the cavalier nature that in the way we're using these. So just wanted to throw that out there. If you have any questions, talk to your doctor about restless leg, talk to them about augmentation and rebound, talk to them about thoughtful use of these dopamine agonist therapy. And if you feel like you're not getting that from your current provider, whether they're a primary care doctor or a sleep doc, seek somebody out with specialized understanding and expertise in restless leg because it will pay dividends over your lifetime. That's it. Thanks very much for tuning in. We'll put the Harmony Hall on the Spotify music playlist. And until next week, sleep well.